I'm Dr. Marla Shapiro, a past president of the North American Menopause Society, and I'm joined today by Dr. Vivian Brown, who's an assistant professor at the University of Toronto. So, at the North American Menopause Society, we encourage all kinds of practitioners, and we have primary care practitioners, and we have obstetricians and gynecologists. So as a primary care doctor, what is the role that the clinician plays, and is it any different than it would be if you were seeing an OB-GYN?
I think that's a great question, and as a primary care practitioner, when I look at a woman, I'm not just looking at gynecology. I'm looking at her in a holistic way. I'm looking at her at midlife changes, and I'm thinking all about prevention. And I think as a primary care provider, we're really looking at this woman at this particular stage of life and helping her plan the next 20, 30, 40 years. So we're looking at cardiac risk, we're looking at bone health, we are looking at gynecology as well. We're looking at preventions like immunization, and really trying to help her make good decisions for the next stage of her life. So I think we look holistically rather than just at the gynecologic situation.
When we think about that term, patient-centered care, what does that mean for primary care?
I think primary care is really looking at one patient at a time. And so patient-centered care looks at you and says, what are your issues? What's your family history? What's your situation in terms of underlying chronic disease? What is the most important area we should be focusing on? And so at this midlife juncture, when women come in to have that assessment, we're trying to personalize it to look at her risks as opposed to the risks of the whole population. And whether that means looking closer at breast cancer risk in someone with a family history, or cardiac risk if someone has significant changes with hyperlipidemia and hypertension, we're trying to personalize that overview at midlife.
And the relationship between primary care and OB-GYN, can you speak to that a bit?
Well, I think NAMS shows us what the relationship is. It's completely collaborative. What we really understand is that not everything in a woman's midlife issue is gynecologic, but we do want to share information, share patient care, depending on what her situation is. So for example, if she's having postmenopausal bleeding, I'm going to bring in the gynecologist to look at an endometrial biopsy. And I think that idea of collaboration is exactly what NAMS fosters. We're all on the same team when we're looking at midlife women. Everybody has their own lens or their own perspective, but I think the relationship is completely collaborative.
Terrific. So in terms of the role that NAMS has with primary care?
NAMS, and I've been a member of NAMS for quite some time, but NAMS gives us the guidelines, NAMS gives us the template to follow, and NAMS helps us have the confidence to handle women in midlife. In Canada, women generally see their family doctor before they see any other specialist, and often they don't need a specialist when they're seeing a NAMS certified menopause practitioner who's comfortable with the issues of medications, of choices, of decisions at this stage of life. And that's what NAMS does. It gives primary care the confidence to be that primary care physician and not necessarily refer to a specialist if it's not really needed.
Thank you.